I'm really honored to be here, and I'm going to switch your attention from, so we've heard about evidence-based interventions both in prevention and treatment of PTSD, and I want to switch to implementation mode. So how we would translate all those knowledge, neuroscience-based, evidence-based research into a real life and practice. And I as well want to highlight the need for those steps and those translations, because when we talk about humanitarian field or field of complex emergency, when the number of people affected by a natural disaster or war is just enormous, when we talk about millions of people in need and at risk, we have to think outside the box, and there are different types of approaches applicable. So, for example, the framework is to incorporate the support and mental health and psychosocial support into other important sectors like primary care and education and support with living or basic needs. So this actually shows that, like, so far we were talking more about specialized mental health services given by well-trained psychiatrists or psychotherapists, but going back again to the needs and the number of people in need, there are more layers and more steps and more opportunities on the level of self-care, on the level of a community care, and on the level of primary care mental health services. So today I'm going to talk about self-care and how we can support prevention and early identification and enhance help-seeking behavior in people who were exposed to trauma. And one of the lessons learned for me, I would share my personal experience, was that the value of this stepped care approach that helps us to save costs and resources and time. And recently several papers were published, and we know that the specific type of exposure, war-related stress, causes a lot of distress and anxiety and depression symptoms and post-traumatic symptoms. However, when we ask those people what is most challenging for them, then they say, tell us not about the trauma itself or symptoms of PTSD. They would say that they worry about their close ones. They worry how to settle in new environment, new city or new country, where to find a place to stay, a work contract, or where to teach children. So we shouldn't forget about the balance between focus on traumatic experiences, timing, of course, is very important, and focus on social stressors and how we can address those. And even though that 45% of the respondents in the mentioned about survey had moderate and severe levels of distress, it doesn't mean that they're coping not well with their daily life and in their functioning. So if people are still able to effectively perform their daily activities, their work, and control their emotions and maintain a positive picture about themselves and others, and maintain valuable relationships, and as well be able to shift attention when they're catched with the anxiety or some ruminations or intrusions, and being flexible. This means that they're coping well, and actually we are testing this now on Ukrainian population in Ukraine, giving them this coping efficacy scale and as well continuous traumatic stress scales, because the single event, first type event, is not the same as the ongoing stress, and you would see other types of symptoms like restlessness and lack of motivation and hopelessness and a feeling of injustice. And what we have seen in many, many examples, so when a natural disaster happens, when an emergency happens, people, actually we are quite bad at doing nothing, so we rush to provide support, but it doesn't always mean that the support is given actually do not harm. And this focus on traumatic memories in early hours and days actually is harmful. And we know that interventions given within the golden hours, within few hours, few days after the exposure are critical because, as Lisa said, if you would ask people about what have happened, this might probably lead to traumatic memory consolidation and would become a core symptom of PTSD, like flashbacks or intrusions or traumatic memory. So, but then going back to real life, we know what works, what doesn't. How can we approach those large number of people at the same time? We would never have enough specialists, volunteers, social workers, psychologists to provide immediate support within the first hours and days. And that's why we know that digital interventions might provide us this unique opportunity. Based on our literature search and clinical practice, we know what exactly works for psychological interventions and for pharmacological interventions and within those critical periods of time. And I'm so happy to learn that more developments are taking place, and in our guideline we have divided those recommendations into different domains and based on type of population, based on timing, and based on type of intervention. And we have as well a research domain, so those interventions that that are promising. However, going back to practice, what we were able to do is to translate those recommendations to people into a dialogue. And we encrypted this dialogue into a chatbot intervention. So probably each participant of this symposium have ever communicated through their phone with chatbot, asking some questions, receiving some information. So we thought that it's really important at the early stage after the trauma exposure to engage people into conversation. Because due to, urgent basic needs and due to life threats, it's really difficult to keep attention for a long time. You might read like 3 sentences, but you cannot read 5 sentences. Your brain just, pushing you to move faster, move forward. So that's what we did, and we launched this chatbot on the second day after the war has started, full-scale invasion has started in Ukraine, and we have 100,000 users activated this chatbot so far. And talking about golden hours, we were able to reach 40,000 people within the first month. And the recommendations or the dialogue is based on essential principles, which is as well a part of first psychological aid. And in the dialogue, and participants or users of the chatbot can choose the answer to the question, meaning that the chatbot is a decision tree, so it's not artificial intelligence driven. We drafted the whole script, so we know exactly where a person and which kind of recommendation they will get. And we encourage them to seek for a safe place. We provided them information, reliable information, where those safe places are situated. We've enhanced or promoted connectedness, reminding them what kind of questions, for example, they might ask to their close known relatives or neighbors, provided them some exercise on how to cope with acute stress. And as well, we had incorporated from the very beginning the opportunity to apply for a session with a psychologist online. So meaning that those who felt that it's not sufficient for them, so the information about normal reactions to abnormal situation and those exercise doesn't help them, so they could immediately apply for this session free of charge and receive that. And actually we know that more than 10% of our users applied for this opportunity and received support. And through this platform called Tell Me, we learned that there are more, I would say, complaints or more requests that were not part of our intervention at the very beginning, related to mood swings and being in conflict with close ones and being angry, being hopeless, etc. And we asked our users how would they rate this intervention, and we know that majority said that it's satisfactory, it's fair, or it's even wonderful in 38%. But there were as well feedbacks and people said that it didn't help or it didn't work for them. So what we learned from those feedbacks, that people really appreciated that this was available around the clock, that this was free of charge. They felt that the resources we put there were trusted and reliable. It was easy to use, not for all, of course, users, but this was quite common. That it was logical and very short and to the point, without any extensive reminders or questions or advertisements. And many of them said that this was a great alternative when there was no one to support, meaning that we were able to target people in areas which are difficult to reach with, people, with psychologists or professionals. And there were specifically comments, a number of comments that struck me, is that they were thankful that there was no need to communicate with human. So what trauma does to us is it makes us feeling quite isolated with our experiences, lonely, and unfortunately it overwhelms us not only with fear but as well with guilt feeling of survival and shame. And many people in complex emergencies, they feel embarrassed to ask for support of a live person. They feel that there are much more people in more specialized needs. So many surveys said that Ukrainians feel that there are other prisoners of war or people of other types of violence in need. So they are afraid to apply, I would say, or just don't dare. But as well, we got a feedback what was not good, and actually we saw that there is a potential appetite for artificial intelligence-driven chatbots. So people were willing to talk to chatbot, ask personalized questions, receive personalized responses, and a number of needs were not met. And we made this age restriction, and of course adolescents were texting us why we can't use this tool. So this gave us an important feedback, and we made a number of changes in the initial version of chatbot. We added extra branches with for example, the most attended were irritability and anger, anxiety, and negative thoughts. And as well, now when we have all this data, and we know actually that people use chatbot not just once, but on a number of occasions, what we can do is that now we can build some models and use machine learning to start looking at trajectories, and I would say feed the algorithm with the data in order to be able at one day to have this prediction about the outcome and prediction about the diagnosis. And and one more thing, so this chatbot tool was developed more as an acute response for acute phase, really to help people to deal with their panic attacks, sitting in a shelter, not being able to cope with the fear of death. But we are working as well on an intervention for people in adversity who stay for a longer term, for example, in refugee camps or shelters, when they need more coping skills on how to adjust and adapt. And this is WHO-based intervention called Doing What Matters in Times of Stress, and it has more modules, it's more structured, and it gives some strategies and meditations for people, and it's based on acceptance and commitment intervention. So the idea is that digital intervention is one solution, task shifting and task sharing is another solutions, and we test those approaches and implement those interventions in 3 bordering to Ukraine countries, and we'll see what will be the outcome next year. And as the summary, I would like to say that digital interventions are potential and important field to have more evidence-based research on its effectiveness, but it's of great need. Having this opportunity to talk to you, I would like to invite you for a few online meetings that we are organizing as the chairs of ECNP Traumatic Stress Network together with Professor Vermitten, and we would have a meeting on PFA and meeting on transgenerational trauma. So feel free to contact me and I will share with you details. Thank you so much.